Hello everyone, my name is Darren Powlis and my project presentation is on the use of early skin-to-skin contact in newborn infants. Each year, an estimated 4 million infants die within the first 4 weeks of being born. Mortality rates are related to hypothermia, could be related to rate of weight gain, and even acquiring an infection. Skin-to-skin contact has been associated with improving breastfeeding, cardiorespiratory stability, and improving responses to procedural pain. Some advantages for the baby of doing this practice in the first few hours of childbirth include thermoregulation and decreasing negative consequences of stress. The evidence-based practice of utilizing the skin-to-skin contact formulates an essential component of nursing routines while working with newborn infants to reduce mortality rates and improve growth and development. My PICO question is related to the population of newborn infants and to address the clinical practice problem of infant mortality rates. The intervention is to assess the use of early skin-to-skin contact and the comparison of the results to those who are provided care without the prioritization of early skin-to-skin contact or standard care. The outcome is to review the thermoregulation and the impact on the mortality rates, and the time frame is to review the effects of skin-to-skin contact within the first week after childbirth. While acquiring evidence, I used the research database ASU OneSearch. The specific search language was early skin-to-skin contact, and the parameters I used was the full text online, peer-reviewed journals, articles published in the last 5 years, which was 2018 to 2023, and the Boolean operators I used were AND for both randomized control trial and infant development. The first research article used was a randomized control trial. The intervention group was encouraged to do the skin-to-skin contact and to start that immediately after allocation and to provide as close to continuous skin-to-skin contact as possible, aiming for above 18 hours a day in prolonged sessions. The control group was managed in an incubator and under a radiant heater in the same room as the intervention neonates, and the caregiver could touch and feed, but skin-to-skin contact was not permitted until the neonate was stable or met the stability criteria at above 24 hours after admission. The independent variable was the skin-to-skin contact, which was started immediately after allocation. The primary dependent variable was all-cause mortality at 28 days. The secondary dependent variables were time to death, stability at 24 hours, use of the stability of cardiorespiratory and preterm infant score, receiving oxygen, hypothermia at 24 hours, exclusive breastfeeding at discharge, daily weight gain, suspected infection, and duration of admission. This study concluded that there was a reduction in hypothermia reported from the intervention group receiving early skin-to-skin care. However, the median hours receiving the skin-to-skin care was 6.7 hours per day, which was less than the recommended 18 hours per day, and likely influenced by the challenges to prolonged periods of skin-to-skin contact, such as interruptions to medical procedures, maternal illness, and routine neonatal cares. The other finding was that it improved stability score at 6 hours postnatal. The next research article was also a randomized control trial. The intervention group was separated into mother NICUs, which had beds for the mothers and reclining chairs, and the control group remained in the existing NICUs. The control group infants were transferred to the NICU without their mother, therefore were provided express breast milk, and skin-to-skin care was provided in short sessions after a minimum of 24 hours of age. The independent variable was the immediate skin-to-skin contact and to assess mortality within the first 72 hours and within the first 28 days of age. The dependent variables in the study were hypothermia, hypoglycemia, suspected sepsis, time to stability, exclusive breastfeeding at discharge, exclusive breastfeeding at 28 days of age, maternal satisfaction with care, maternal depression, and any deaths at the 72 hours of age. The groups were monitored every 6 hours and data was collected during the duration of the skin-to-skin contact and hospital stays. The risk for death was found to be lower in the intervention group for infants who received more hours of skin-to-skin contact per day, with most mortality rates being related to sepsis or preterm complications. The hypothermia was recorded at 5.6% in the intervention group versus 8.3% in the control group, with the other outcomes being similar, such as the incidence of hypoglycemia and exclusive breastfeeding. Delivering early skin-to-skin contact improves the chances for survival among newborn infants and reduces the chances of hypothermia. Those infants that received immediate skin-to-skin contact after birth and longer durations of skin-to-skin contact had significantly lower mortality rates. The implementation plan will begin with the strategy to create awareness within the organization. I will address the evidence in an announcement via email and further reinforce it in staff meetings, including the promotion of the advantages and anticipated impact of the use of early skin-to-skin contact. The next step will be building knowledge and commitment by working with a team within a focus group for implementing the change. I will collaborate with healthcare organization leaders to create learning modules to keep the discussion ongoing and widespread throughout the organization. I will also create a timeline that allows the practice to implement widely among all staff, such as 2 to 3 weeks. The next phase would be promoting action, in which a standing order will test the practice change and contribute to maintaining consistency. The development of a new standard of care can be expected with consistency in practice and recognized with positive trends and performance stability. Evidence will need to be gathered from the clinical experts and patients. For the clinical experts, we are looking at the organizational leaders, OBs, general practitioners, neonatal nurse practitioners, pediatricians, neonatologists, maternal and child health nurses, and nurse managers. The key stakeholders here are going to be the organizational leaders, newborn caregivers, and nurse managers. And I will gather the evidence from the clinical experts by first introducing the proposed practice change in person during staff meetings. I will further inquire in-depth questions by requesting the response in an email. While gathering evidence, I'm going to need to know their educational credentials, years of experience, and background experience working with newborn infants. Due to the nature of the patients involved being newborn infants, evidence will be gathered from the admitting mothers in the unit as well as their family directly involved in the newborn infant's care in the form of an in-person survey. I will gather the evidence from the family and the mothers that are stable upon admission. Questions I will ask the mothers and newborn caregivers are focused on exploring their experience in their progression of their newborn's health with the use of skin-to-skin contact and if they have different experiences with other forms of practice. If the proposed practice change is not accepted by the patient, I will modify the delivery method. The evidence obtained from the surveys and feedback will be implemented in the proposed practice change by strategizing the procedure to maintain a patient-centered practice. Communication and marketing within the organization will be used by posting newsletters, proposing the topic for continuing education programs, and getting staff involved by creating a fun contest for coming up with slogans and logos. I will follow through with the communicating transparency on the medical unit's progress by posting weekly results. Communication with the patients and families will be marketed by presenting one-on-one demonstrations and providing patient education with evidence that enlightens their knowledge on the benefits of early skin-to-skin contact. Additional marketing will be posted in the rooms for the approved slogans and logos created by staff promoting the practice change. Evaluation and assessment will be done with the collection of data in the patient's room by the nurse, at first within 6 hours postnatal, 24 hours postnatal, then daily until discharge. The information will need to be provided to the nurse managers that includes the time, frequency, and length of consistent initiated skin-to-skin contact. In addition, important variables to record are the results of frequent assessments of vital signs, weight, thermoregulation, time to clinical stability, presence of hypothermia, and breastfeeding status. In addition to the newborn infant status, the mother and family or caregiver will need to be evaluated for their experience, comfort levels, and breastfeeding confidence. In summary, early skin-to-skin contact is an intervention that will help decrease the risk of newborn infants developing complications, such as thermoregulation and infection, decreasing negative consequences and stress, improving stability, and other things, therefore reducing the risk of mortality. Gathering evidence from clinical experts and patients is important to successfully implement the proposed practice change. Having a plan to implement the change and being prepared to make modifications is necessary to keep the conversation ongoing and marketed. As results begin to present in favor of early skin-to-skin contact through consistency and improved patient outcomes, the practice change will become standard newborn care.